Hello, fellow warriors. Here we are with news from the website prostatewarriors.com.
Thank you. It's a real honor to be here for this deep dive.
Yeah, we've got some incredible stuff to get into today. I mean, imagine treating aggressive prostate cancer, not by, adding more toxic drugs, but by completely stopping therapy and actually watching the patient thrive.
Right. It sounds totally counterintuitive, but it's happening.
Exactly. So today we are breaking down the absolute bleeding edge of oncology data to find out how radical ideas like that are functioning out in the real world.
Yeah, and the landscape is just moving incredibly fast right now.
It really is. So the mission of this deep dive is simple. We want to take the incredibly complex data coming out of the latest clinical trials and real-world evidence and, well, translate it into actionable understanding for you. We're decoding what this all means for the future of your treatment.
And to make sense of it all, our focus today is going to begin strictly with clinical trials. We'll start at the top with the massive, practice-changing Phase 3 data.
Right, the big stuff.
Exactly. And then we'll work our way down through Phase 2 optimization trials all the way down to the Phase 1 innovations that are entirely redefining how cancer cells are targeted.
And then finally, we'll step out of that pristine lab environment, right? Just to look at how these highly advanced therapies actually perform out in the messy, complicated real world.
That's the plan.
Okay, let's unpack this, starting with the Phase 3 trials. This is where those massive, robust data sets reside, right? The kind that actually reshape the standard of care.
Yeah, specifically, we're looking at the PSMAddition trial. That's for men with metastatic hormone-sensitive prostate cancer.
Right. And what was the big question they were asking there?
Well, standard care right now usually involves a double hormone therapy backbone. So,
Okay.
Androgen deprivation therapy combined with an androgen receptor pathway inhibitor.
Right, the standard double blockade.
Exactly. The researchers wanted to know what happens if you take that standard backbone and add a targeted radioligand therapy to it right up front.
Okay.
Specifically, they added Pluvicto, which is also known as 177-Lu PSMA 617.
Right. And just so you, the listener, have a clear picture, 177-Lu PSMA 617 is essentially this radioactive payload, right? It's attached to a homing beacon that seeks out the PSMA protein on the surface of prostate cancer cells.
That's a great way to describe it. And the numbers they reported from doing this were just striking.
I'll say, adding the radioligand therapy resulted in a 58% lower risk of PSA progression. That's a hazard ratio of 0.42.
Which is a massive drop in risk, truly massive.
And it also showed a 28% lower risk of a radiographic progression or death, right?
Yeah. Seeing an 87% rate of patients keeping their PSA below 0.2 at 48 weeks in the treatment arm, that's remarkable.
Wow.
But, as with all newly reported Phase 3 trials, there's a caveat to keep in mind.
There's always a caveat.
Always. The overall survival data, which is, the ultimate gold standard in oncology, it's trending positive, but it's not yet mature.
Okay, and here's where I have to push back a bit.
Go for it.
If the overall survival data isn't mature yet, how can you sitting in a doctor's office feel confident that this is an actual win right now? We're talking about adding a radioactive therapy to an already heavy hormone regimen.
Right.
If we don't definitively know it extends life yet, isn't that a huge leap of faith?
That is the crucial question. It's the exact dilemma the whole medical field wrestles with constantly.
So how do they justify it?
Well, to answer it, we have to look at a post hoc analysis from another major study, the Talazoparib trial. This was presented at the American Urological Association.
Okay.
They proved statistically that radiographic progression-free survival, or RPFS, is a highly accurate predictor of overall survival.
Okay. Let me see if I can put an analogy to this for the listener. Relying on RPFS is kind of like looking at the check engine light on your car, right?
Exactly.
Like, if a new oil treatment keeps the check engine light from coming on for an extra 2 years, you can be highly confident that the car itself is going to stay on the road longer, even if you haven't, driven it until the wheels fall off yet.
That is a perfect way to conceptualize it. In that Talazoparib analysis, across almost all the subgroups they looked at, even patients with HRR-deficient mutations and BRCA mutations, the correlation between RPFS and overall survival was above 0.7.
And in statistics, anything above 0.7 is pretty strong, right?
Very strong.
Yeah.
It fully validates using those clear scans as a primary endpoint, so we don't have to wait a decade for the overall survival curve to mature.
Right, because waiting a decade ignores the aggressive nature of the disease right now. But, waiting for long-term survival curves also ignores the physical toll these heavy regimens take on you on a daily basis.
Oh, absolutely. The toxicity is real.
Which makes me wonder, Are we always going to just throw more radiation and hormones at the wall? Or is anyone looking at how to safely dial this back?
Well, that exact line of questioning is what drives the Phase 2 space. Phase 2 is really where we see the most creative clinical thinking.
Like the ADREAM trial.
Yes, a brilliant example. In oncology, the default instinct is almost always to treat continuously until the cancer progresses. But the ADREAM trial explored that radical idea you mentioned earlier, stopping therapy safely.
And this was for a highly selected group of men, right? Guys with metastatic hormone-sensitive disease who had an exceptional response to their initial therapy.
Right, exceptional responders. We're talking about men whose PSA dropped below 0.2 and testosterone below 50.
And they just completely stopped their hormone therapy, which is wild. And the results are incredible, right? 41% of them were able to remain off treatment with their testosterone, fully recovered at 18 months.
It's huge because the psychological and physical break from therapy, it just cannot be overstated for you or anyone going through this. Restoring testosterone means restoring energy, muscle mass, just overall quality of life.
But biologically, I mean, why does that even work? How does a patient go from having aggressive cancer to needing no drugs at all for a year and a half? Is the cancer just gone?
Not exactly gone. It's likely a shift in the tumor microenvironment.
Okay, what does that mean?
The intense upfront therapy eradicates the bulk of the androgen-dependent cancer clones so thoroughly that the few remaining cells enter this sort of dormant state.
Ah, I see.
A treatment holiday doesn't just give your body a rest. It actually removes the continuous evolutionary pressure that forces the cancer to mutate and become resistant.
That makes a lot of sense. Though it is a phase 2 single-arm study, so the 10-year implications are still kind of unknown, right?
Yes, exactly. But just proving that a treatment holiday is biologically feasible for exceptional responders, that's a massive paradigm shift.
Quality of life is such a huge part of the conversation right now. And that brings up the ARACOG trial.
Yes.
This was a head-to-head comparison looking at the cognitive side effects between two very common hormone drugs, darolutamide and enzalutamide.
Right, because cognitive decline is a major, totally valid fear for patients on androgen receptor inhibitors. The ARACOG trial used remote, automated testing to measure memory, attention, and executive function over 24 weeks.
And the data showed that darolutamide resulted in significantly less cognitive decline than enzalutamide.
Right. Significantly less, yes.
But the fascinating detail here is the learning effect.
Oh, this was so interesting.
Right. The patients taking darolutamide actually improved on the repeated memory and attention tests. Because they took the test multiple times, they practiced and got better at it.
Exactly. But the patients on enzalutamide worsened.
Wow.
Yeah, the drug's cognitive impairment actually offset their ability to learn and improve on the test.
So why the difference?
It comes down to the molecular structure of the drugs. Darolutamide has a distinct structure that makes it much harder for the drug to cross the blood-brain barrier.
Okay. And enzalutamide?
Enzalutamide crosses much more freely. It interacts with receptors in the central nervous system, which manifests as that mental fog or deep fatigue.
It just proves that not all drugs in the same class are created equal when it comes to your daily experience.
Not at all.
That distinction is so important. Now, consider how trial designers are getting smarter about genetics, too, like the TALENT trial.
Right. The Phase 2 study evaluating Talazoparib alone versus Talazoparib combined with enzalutamide.
This is for patients with HRR-deficient metastatic castration-resistant prostate cancer who have already failed Abiraterone.
Yeah. But what stands out to me about the TALENT trial isn't just the drug combination itself. It's a brilliant trial design quirk.
The cap?
Yes. They specifically capped the enrollment of patients with ADM mutations at 15%.
But why cap it? Usually researchers want as many patients as possible who fit the broad genetic profile, don't they?
They do, usually. But the ATM mutation is tricky. While it falls under the broad umbrella of HRR deficiency, tumors with ATM mutations often respond very differently to PARP inhibitors, like Talazoparib, compared to, say, tumors with BRCA mutations.
Oh, I get it. So if they let ATM-mutated patients flood the trial, those unique resistance mechanisms could artificially drag down the efficacy data for the whole group.
Exactly. By capping them, they prevent the ATM subgroup from skewing the BRCA data.
It really proves that the field is learning to treat the specific exact mutation, not just the broad genetic category.
Precisely.
But what if the cancer doesn't have an ATM or BRCA mutation to exploit? If we're talking about priming the immune system, is there a way to force the cancer to become vulnerable?
That's a great transition.
Thanks, because that leads directly into the trial combining bipolar androgen therapy or BAT, given before the cellular immunotherapy Sipuleucel-T. I like to think of this approach like tenderizing a steak before cooking it.
That is a very apt analogy.
Mm.
Bipolar androgen therapy involves shocking the prostate cancer cells by alternating between extremely high and extremely low levels of testosterone.
Right.
In this phase 2 trial, they gave patients 2 cycles of BIAC to essentially agitate the tumor environment and then administered the Sipuleucel-T immunotherapy.
But wait, how does flooding the system with testosterone actually hurt the cancer? Doesn't prostate cancer feed on testosterone?
It does, which is exactly why B sounds so counterintuitive. But prostate cancer cells adapt to the low testosterone environment of standard therapy.
Okay, so they get used to a drought.
Right. So when you suddenly flood the system with a massive dose of testosterone, the cancer cells become overwhelmed. As they try to divide and replicate, the sheer volume of androgen actually tears their DNA apart during the cell cycle.
Wow. And that massive cell death releases tumor antigens, which primes the immune system.
Exactly.
And the tenderizing worked beautifully here, didn't it? By giving B for first, they led to a 100% T-cell proliferation response.
Which is phenomenal.
Yeah.
Historically, Sipuleucel-T alone only achieves that kind of robust immune activation in about 50% of patients.
That's a huge jump.
It is.
Yeah.
However, we do need to temper the excitement just slightly.
Why is that?
Because this was a single-arm study comparing against historical data, so we can't definitively prove that the BD alone caused the increased response.
Ah, I see.
It strongly suggests a potentiation hypothesis, meaning BAY is a highly effective immune primer, but a randomized trial is required to isolate that variable completely.
Fair enough. But what happens when the cancer outsmarts our best weapons? Like, what happens when a patient progresses after receiving 177-Lu PSMA 617?
That specific problem introduces the CONVERGE-01 phase 2 trial.
Right.
This is where radioligand therapy takes its next evolutionary step. CONVERGE-01 introduces CONVES-010, which is actinium-225 rosaptamab tetraxetan.
And the critical difference here is the radiation type, right? Because 177-Lu PSMA 617 uses a beta emitter, but actinium-225 is an alpha emitter.
Yes.
Wait, how does an alpha particle actually shatter DNA differently than a beta particle?
It's entirely a matter of physics. Beta particles are essentially high-speed electrons. They bounce around, travel a longer path length, and cause single-strand DNA breaks.
And the cancer cell can sometimes repair that kind of damage and survive?
Exactly. Alpha particles, on the other hand, are heavy. They consist of 2 protons and 2 neutrons.
So it's like swapping out a standard rifle for a bazooka.
Pretty much.
Alpha particles are massive. They travel a very short microscopic distance, but they hit with devastating force, causing catastrophic double-strand DNA breaks that the cell simply cannot repair.
Precisely. It has a high linear energy transfer. And in this trial, using the 45 kilobecquerel per kilogram dose, 45.4% of heavily pretreated men whose cancer had already survived the standard lutetium therapy achieved at least a 50% decline in their PSA.
That's amazing. It shows that even when a target like PSMA seems exhausted by one type of radiation, altering the physics of the payload can completely resensitize the disease.
It's a huge step forward.
Well, if we were already engineering radioactive bazookas, what happens when we look at the drugs being born right now?
The phase 1 frontier.
Exactly. Moving into phase 1, we see the earliest human trials looking at entirely new mechanisms to outsmart cancer. And the first one is ABBV-969. I'm fascinated by this.
It's incredibly innovative.
It's an antibody-drug conjugate, or ADC. I like to call it the smart bomb approach.
An antibody-drug conjugate is exactly that, a guided missile. It uses an antibody to find a specific protein on the cancer cell, binds to it, gets internalized, and then releases a highly toxic chemotherapy directly inside the cell.
But ABBV-969 is special because it's dual targeting, right? It seeks out both PSMA and another protein called STEAP1.
Yes, and it delivers a topoisomerase I inhibitor payload.
And the results. In heavily pretreated patients, 67% saw a PSA decline of at least 50%, with a 45% objective response rate.
Let me just emphasize how big that is. To see a 45% objective response rate, meaning actual measurable tumor shrinkage on a scan in a phase 1 trial for heavily pretreated castration-resistant disease, that is highly unusual.
Wow, so the dual targeting is the real key to this success then.
Definitely. Prostate tumors are heterogeneous, right? So some cells might stop expressing PSMA to hide from therapy.
Right.
By targeting both PSMA and STEAP1 simultaneously, the drug casts a wider net. It prevents the cancer from using antigen escape to survive.
Were there side effects?
Anemia was the main toxicity, which is manageable. But the efficacy signal is undeniable.
It's just brilliant engineering. The other phase 1 trial in the stack is for a drug called HRS-5041. This one is an oral androgen receptor degrader.
Yeah, and the mechanism of action here is a fundamental shift in how the androgen receptor is handled entirely.
Right, because traditional inhibitors like enzalutamide or darolutamide, they work by blocking the receptor. It's like putting a deadbolt lock on a door to keep the cancer from getting the hormones it needs to grow.
That's a good way to look at it.
But eventually the cancer mutates, it picks the lock, or it just breaks the door down. HRS-5041 doesn't bother with a lock. It removes the door entirely by degrading the receptor so it ceases to exist.
A perfect visualization. Over time, cancer cells develop mutations in the ligand-binding domain of the receptor AR-LBD mutations.
Okay.
These are therapy-induced mutations created specifically to survive standard inhibitors.
So they adapt to the lock.
All right. HRS-5041 is designed to tag those mutated receptors and drag them into the cell's internal trash disposal system, which is known as the ubiquitin proteasome system.
That's wild, and the phase 1 data backs up the theory beautifully. At 240 milligrams twice daily, nearly half, 48.4% of the patients who had those specific mutation-positive tumors saw a 50% PSA decline.
Right, compare that to only 20% of the patients with wild-type or unmutated receptors.
That differential activity really is the proof of concept, isn't it?
Absolutely. The drug is doing exactly what it was designed to do: hunt down the mutant proteins driving resistance. It even worked in a patient with liver metastases, which is notoriously one of the most aggressive, treatment-resistant forms of the disease.
Incredible. Well, we have spent a lot of time in the laboratory and the clinic today, but clinical trials are tightly controlled, pristine environments.
Very much so.
Patients are carefully selected, monitored constantly. To really wrap up this data, we have to step out of the lab and into the real world to see how these therapies actually play out in everyday clinics.
And real-world evidence is messy. But it is vital because it reflects the actual population of patients walking into community oncology clinics, not just the elite trial participants.
The Patient 360 dataset is a prime example of this. This looked at over 10,000 patients to settle a debate. When a patient has metastatic disease, should they get an ARPI doublet, meaning hormone therapy, plus an ARPI or a triplet, which adds docetaxel chemotherapy right from the start?
And on the surface, the numbers in this dataset look baffling. The median overall survival was 109 months for the ARPI doublet, 79 months for the triplet, and 64 months for the docetaxel doublet.
Yeah, if you're sitting in a clinic right now looking at your options, this data might look terrifying at first glance.
It implies the strongest medicine kills you faster.
Right. The people getting 3 drugs died faster than the people getting 2. How does that make any sense?
What's fascinating here is the underlying clinical behavior, the selection bias. The doublet didn't inherently outperform the triplet.
Okay, so what actually happened?
What happened is that real-world doctors look at a patient, and if the patient has explosive, high-volume disease like liver metastases, or a Gleason 9 or 10, they immediately reach for the heavy artillery, the docetaxel triplet.
So the triplet group was filled with patients who already had a much more aggressive baseline biology.
Exactly. It's the sickest patients get the strongest medicine paradox.
But the data did reveal a true golden metric regardless of the regimen, didn't it? Achieving a deep TSA nadir under 0.2. Patients hitting that mark on the doublet survived an astounding 200 pity months.
Yes, it proves that the depth of the biochemical response is the ultimate compass for long-term survival.
And that leads to another real-world database study using the TriNetX database. This was a propensity-matched study comparing Abiraterone versus Darolutamide head-to-head.
Right. They matched 363 patients per arm to make it as fair a fight as possible.
And the results were stark. Darolutamide showed a vastly superior overall survival. The median survival wasn't even reached for the darolutamide group during the study, whereas the Abiraterone group hit a median survival of 60 months.
It is a compelling signal, definitely. But this is exactly where extreme caution is necessary.
Why is that?
Real-world databases are limited by what the billing codes and electronic health records actually capture. They frequently miss critical nuances, like exact tumor volume or the patient's performance status, how frail or robust they were when they walked in the door.
Oh, I see. So even with propensity matching, a researcher might accidentally match a frail patient on Abiraterone with a marathon runner on darolutamide just because their ages and PSA levels matched on paper.
Exactly. Residual confounding is a real risk here. These retrospective studies generate brilliant hypotheses, but they do not replace the need for randomized controlled clinical trials to definitively change practice.
That makes perfect sense. Well, I want to finish with one of the most surprising real-world studies in the stack, and this wasn't about a drug at all. It was about muscle.
Yes, the CT-measured muscle quality study.
Right, a Japanese study of 344 men with non-metastatic castration-resistant prostate cancer.
Usually oncology just looks at muscle mass, how big the muscles are. But this study used standard CT scans to measure IMAC, the intramuscular adipose tissue content.
Which means they were looking at fat infiltration inside the muscle itself.
Correct.
It's like looking at the size of a car engine.
Yeah.
You can admire a massive V8 engine, but if you don't realize it's completely filled with sludge, you're going to be pretty surprised when it breaks down on the highway.
That is a great way to put it. Muscle size without muscle quality is a deceptive metric.
Yeah.
They found that muscle quality, or the lack thereof due to fat infiltration, predicted survival much better than sheer muscle size. Patients with higher IMAX, more fat in the muscle, had an 80% higher risk of death.
And it didn't even predict drug response. It didn't mean the drug stopped working. It just meant the patient couldn't physically tolerate the marathon of the disease. But why is intramuscular fat such a deadly indicator?
Because fat infiltration is a proxy for systemic inflammation and physiological decline, which is often linked to cachexia.
Right.
It highlights that the medical community cannot just treat the tumor, they have to treat the host. Nutrition, physical activity, preserving high-quality muscle, these are literal life-saving interventions that need to be prescribed right alongside the advanced radioligands and ADCs.
Wow, what a profound journey. We have covered incredible ground today. We started by redefining how success is measured with rPFS in the massive Phase 3 Talapro-2 and PSMAddition trials.
You did?
Then we explored Phase 2 innovations, finding clever ways to de-escalate therapy safely in ADREAM, protecting cognition with Darolutamide, and deploying tactical alpha particle strikes with Actinium-225.
And we dove into the radical science of Phase 1.
Yeah, utilizing dual-targeting smart bombs and oral degraders that throw the mutated androgen receptor right in the cellular trash.
And finally, we honored the messy, vital, real-world data, proving that deep PSA nadirs and high-quality muscle matter just as much as the drugs prescribed.
It really connects all the dots.
It does. And if we connect all of this to the bigger picture, it raises an important question.
Let's hear it.
If treatments are becoming so incredibly precise that they depend on specific AR mutations, exactly capping ATM genetic alterations, and even measuring the microscopic fat content hidden inside our muscles, will the future of prostate cancer oncology require doctors to treat a patient's metabolic lifestyle and their exact molecular blueprint long before they ever actually look at the prostate itself?
Wow, that is something for you to truly think about as you navigate this rapidly changing landscape. The blueprint and the foundation might just be more important than the building itself. Thank you all for joining us on this deep dive into the latest data. Stay strong and fight on.